Welcome back to the Peptides for Women podcast. I'm Jennifer Woodward, and today we have a special guest, Dr. Jason Pencek. Dr. Pencek is a chiropractor and nurse practitioner. He started working in medicine as a registered nurse in 2010. He quickly realized that traditional Western medicine has failed many people. He went back to school in 2012 to study for his chiropractic doctorate. He attended National University of Health Sciences, and while in school, he started training for IV therapies. The scope of practice of chiropractic medicine was too limited, so he began his nurse practitioner degree at Olivet Nazarene while still attending National University of Health Sciences. He's been trained in dozens of therapies such as IV nutrients, IV chelation, platelet-rich fibrin joint injections, bioidentical hormone replacement therapy, peptide therapies, neural therapy, ozone therapy, perineural therapy, stem cell therapies, and exosome therapies. He's made his goal in life to improve longevity and health span in all of his patients. Very exciting stuff there, Dr. Pencek. Thank you for being willing to come on the show. How are you doing today?
Wonderful. Jason is fine, by the way, Jennifer. Please, that's fine.
All right, Jason, you got it. So you are definitely coming at us from the clinic today. You also run a very busy practice. You're in Chicago,
hmm
correct?
Correct.
Okay. And I'm familiar with a little bit of your stuff. I really want to talk to you because you've been using peptides clinically for over
hmm
6 years. Can you tell
hmm
us how you first got started and what drew you into the peptide space?
Of course. About 7 years ago, all of my friends decided that I'd been in school long enough that I should be prescribing them steroids and growth hormone. Bunch of guys in a group chat. We're just being guys. And 7 years ago, they said, "When are we getting the growth hormone? When do we start getting this stuff? You've been practicing for a little bit. How do we get it?" And so I, of course, said, "I have no idea about growth hormone. It's not something you get taught in school ever, really. They don't teach you how to prescribe it or how to use it. And it's not on label to treat people for growing muscles. This is not an on label use for it." So I started doing some research to figure out what growth hormone was, how to use it, how to figure out even how to get it. And I found growth hormone peptides accidentally. The first thing I put in was growth hormone. All of a sudden, growth hormone peptides just popped up. I started researching them. I started just doing some cursory, hey, what are these things? Read some news articles on Google like anyone else. And my best friend happened to be running IV clinics. She was opening IV clinics for other doctors. She'd go in and set up an IV clinic. One of the doctors in New York that she worked with was actually utilizing peptides in practice already. And so she said, let me ask her. So this woman sent me all of her white pages on a bunch of research on peptides, mostly just CJC, 1295 ipamorelin, tesamorelin, ipamorelin, and then she sent me stuff on BPC 157. I was like, I don't know what this stuff is, but it seems really interesting. And I believe I had one pharmacy I worked with at the time that had a mix of sermorelin, GHRP2, GHRP6. So I said, I'm going to just order this stuff and Google how to use it. No idea what I was doing. And at the same time, I found one of the first seminars being taught by a company called A4M that had their peptide seminar. It was like a beginning class. It was an online course. I got that. Dr. Seeds was one of their guys teaching. I got into something called IPS, it's International Peptide Society. Dr. Lavelle and Dr. Seeds were kind of part of this to begin with. And then after that, I went to my first probably peptide seminar. Let's see, that was in December. And maybe in, I think February was when I went to my first course with Dr. Seeds. And I met him in person and he was his mastermind. He just started lecturing. This is probably just a few months in. And I was like, this is the coolest stuff I've ever heard of. I can't believe it does all this stuff. I couldn't believe it. I was like, this isn't real. Like this is not how medicine is practiced. We're giving drugs all the time. This doesn't make any sense. I'm doing IVs at the time. I was doing hormones at the time, some joint injections. And I started using peptides. And all of a sudden, I told my friends, hey, I've got actually some options. And the
Mhm.
ironic thing still is to this day, these friends of mine only get testosterone from me. They don't do any peptides with me. I've begged them. I'm like, I have options. They're like, yeah, no. I'm like, but you wanted me to find all this information. I did this for you. So anyway, I use a lot of peptides in practice and just slowly grew. In the beginning, when my first patients came to see me and she was young, probably in her 20s, one of the first peptide patients I had, I made some comment. Just got back from a seminar for the peptides, and she had Crohn's, no, ulcerative colitis.
Mhm.
And so I said to them, like, I just went to the seminar. I learned about BPC 157. She goes, oh my God, I've been looking for someone to give me BPC 157. I literally been looking for this for like forever. I've done stem cells, I've done fecal matter transplant, I've done IVs, she just named everything she'd done. So we started giving her BP757. It was one of the first things that she was like, oh my God, this is actually working. This is actually helping my ulcerative colitis. So she was so impressed with the oral BP757. I was like, what is this stuff? It's magic.
Mm.
So I got more and more into it. I started doing more and more peptide therapies. And then when the GLP-1s hit, I want to say 2020 is when I had semaglutide. It was when it first came to market. I knew about GLP-1s. Liraglutide was one I used before because I'd heard at the first seminar we talked about GLP-1s. The very first seminar 7 years ago, we talked about GLP-1s. These are going to be amazing. Liraglutide's all that's out right now. The pipeline for sema hadn't even been out yet, but they were saying this is where the future of medicine's going. So when semaglutide came out, I was one of the first practitioners to start using it for weight loss, and I had the dosing all wrong. I don't know what I was doing. I think I gave my first couple of patients 2.5 milligrams, which is the top dose, and I gave them the first 10 patients this. Now, anyone's tried semaglutide out there, you'll know the top dose will make you want to vomit everywhere. So I had patients. I still remember my first patient. He's texting me. He's like, "My girlfriend ate the same thing as me. But I had one thing she didn't eat. I had food poisoning. Like, you got to come give me an IV at home. Like, I'm dying. I'm struggling. I'm so sick." And I was like, oh God, how'd you? And I had, at this point, I'm like, I think it's an adverse effect, but how often does it happen? I had no clue. This is right when Sema had literally just come out. It's brand new to the market. And I went to give him an IV, and he was still sick for days after that. So I've since learned how to use semaglutide much better. After those first 10 patients, I was like, why am I giving him the top dose? This is craziness. So I started titrating. And once semaglutide came out, the peptide practice blew up even more. So that was probably 2 years in. And I was using peptides in practice, mostly growth hormone peptides, some GLP-1s, but people weren't wanting to spend money on GLP-1s because there wasn't a weight loss to it. It's more like, how do I help my metabolic disease? How do I bring some pain levels down? It wasn't being used. It was more expensive than sema and more frequent injections. So I started utilizing peptides. And then, again, the last 5 years, everything's just gotten bigger and bigger. And now I utilize probably 50 different peptides in practice. And they just kind of adjunct my practice. So I always joke there's a peptide for that. I use peptides anywhere and everywhere. I'm on them. I take them. I will never stop taking them. I will always be cycling on and off things. And my whole practice just changed by adding peptides. So that's how I got to where I'm at now.
All right, good origin story. I'm actually curious because you said you weren't using a lot of the GLP-1s for a while, that people were more interested in the growth hormone secretagogues. So you were
Hmm.
doing more of the ipamorelin,
Oh,
tesamorelin.
yeah.
So tell me about that.
Yeah. So I did my first tesamorelin injection. I mean, this must have been, right when I first started, I heard about tesamorelin. And when we first about tesamorelin, we were pushed into this idea that great for fat loss, great for visceral adipose tissue, so fat around the organs, basically. When I heard this at the time is a 30% reduction of visceral adipose tissue, I'm like, oh my God, 30% weight loss. This is not what it means. This is not what it means. But at the time, I'm like, oh my God, I can just burn this fat. And when I first started using peptides, I was probably 40 pounds heavier than I am now. I didn't feel great at the time. So what ended up happening was I started taking testosterone, thinking this is going to be a major change. I'm going to take this stuff, and magically I'm going to burn all my fat off. Let me tell you, anyone that's used testosterone and ipamorelin or CJC and ipamorelin, you will find out it does not. Yeah, it does not burn all of your fat off. You want to believe it does, and I believe it did. I did it for about 2 months, and I put patients on it. Same idea. They're like, we want to burn fat. So all these patients, I had probably 10 patients at once. We're all doing it together. And the end of the time, one of the patients or two of the patients were like, yeah, I'm pretty happy with my results. They were already on the leaner side. They built more muscle. They were like, I learned to burn more fat. They were like happy with the results. But the rest was like, wait, where's the fat loss? I expected to have like 3 inches of my waist down. And what the heck happened here? Well, it is definitely more subtle. I use tesamorelin now, but I switched from tesamorelin to CJC 1295. And I'm like, well, tesamorelin's a little more pricey. We'll go to CJC. It probably will help. I did feel better on it. My energy is better. My mood is better, but I didn't get that fat loss. And that's what everyone was expecting. So I use a lot of CJC 1295 ipamorelin. We don't really use sermorelin that much in practice. Not that sermorelin's bad,
Mhm.
but between sermorelin and tesamorelin, I give everyone tesamorelin any day, all day, because it's a stronger option for growth hormone output. But I started using these growth hormone peptides, and it was a game changer. When I lost my 40 pounds and got in the best shape of my life, it was BPC 157. I was on a little bit of testosterone booster, so I was taking enclomiphene, and then I also was taking growth hormone peptides, BPC 157, and enclomiphene. So those three things. And I was exercising twice a day, every day. I just had more energy. I was able to push myself harder. I was able to like work out twice a day, sometimes 3 times a day, because I felt so much better. My energy was so poor beforehand. And I feel like a lot of people you have in your audience here are like, my energy sucks, right? This is the thing most people come to me for. My energy is so poor. What do I do? We're in perimenopause, we're going to menopause, and a lot of women are stuck. Like, what do I do for this? I'll tell you, growth hormone peptides work amazingly well for helping energy. If anyone doesn't know this, growth hormone goes down by about 15% a decade, starting in your 20s. So by the time you hit 60, you're at 10% of the growth hormone you made when you were in your teens. Now, that is a major drop. And what does growth hormone work on? Brain function, sexual function, immune function, repair, recovery. Sleep is a big one. Everyone complains about sleep as they get older. It's not as good, not as quality. We see improvements in skin, hair, nails, energy, mood, motivation. So growth hormone has a plethora of things it can work on. For me, I ran testosterone. My energy in the afternoon was really bad. So a lot of times see women, I'm saying, hey, if your energy in the afternoon is bad, it's adrenals, testosterone, or it's blood sugar issues. Like these are the top three I see in practice. And very often, and I see low testosterone women, we correct it and they get better. Well, I had low testosterone or mid range. I was fatigued in the afternoons. I started taking testosterone. And as any good scientist, I felt better. And so I stopped it to see, hey, how does it compare to something else? And I added in CJC 1295 ipamorelin and growth hormone peptides. And I had probably 90% of the energy I had on testosterone. I was like, wow, I do feel so much better just taking this. So, and this was when I was 30. God, this has been 33. Yeah, 33 now. So I felt really good taking this. And I was like, well, I added growth testosterone in, and then the together combo was the best ever. But I remember just being on just CJC and Perimenopause. If I take tesamorelin and Perimenopause, I felt great. Like I felt my energy was really a lot better. So I always tell people, it's worth looking into the growth hormone peptides because they actually can change how much better you feel when it comes to energy and mood. And again, this is a big thing. Perimenopause, we start to get into poor sleep. Menopause, poor sleep. If you can correct that sleep by giving something, this is when the peptides really, really reign supreme. And again, not that there's not supplements, not that there's other things you can do. I don't want to take away from these things that are being used in practice by lots of people and by any nutritionists out there and people that are working with health coaches. But I want to say that growth hormone adds another layer. It's something you can't just take orally. You can't just go take a supplement and say my growth hormone is better. There are definitely companies that try to promote oral products to raise growth hormone, and they might say it's going to double your growth hormone. That's great. Well, if your growth hormone is 10% what you made when you were young, and now it gets to 20%, awesome. You still have no growth hormone. So I always want to just tell people the peptides are really great because there is some research. Like for example, tesamorelin and sermorelin both have or FDA approved peptides medications to treat growth hormone to work on growth hormone. So we have these with plenty of human data showing where they do make these improvements. And you can look at the data and see the human data and say, oh, it does work on all these things. So I hope that answers the question. It's a little,
Yeah.
little extra.
No, it definitely does. And I've heard you lecture and say that you're not a huge fan of Summerellin. I actually like that
Mm-mm.
better. I did an ipamorelin tesamorelin blend, and I can see muscle difference with my Summerellin. I
Mhm.
definitely have better sleep with Summerellin. I just feel like it's a little softer for
It
women.
is
So
100%.
yeah.
100%. Now you took testosterone and Perimenopause. So the biggest thing women see on that is bloating. That's like number one. Most women will come
Yep.
to me. Yep. So 10 to 20% of people will get bloating on testosterone and ipamorelin because you push out more growth hormone. When you
Hmm.
push out more growth hormone, you have the potential to have more water and water retention. Now, I will tell you, out of that 10 to 20%, after 30 days, about half those people will have the water retention go away. So if you can maintain, I have patients to reach out to, today, I am bloated, I'm 3 weeks, I'm like, just give it another 2 weeks. If you're still bloated, we'll drop the dose. So typically the next thing I do is drop the dose. I go down a little bit because if I go down the dosing, people typically feel better. And then if it's still not enough, then again, I bump down to something else. But I do see the best results on testosterone, but because of the biggest growth hormone output, I do have more adverse effects. Sermorelin is a lot more soft, you're right. And I would say between testosterone and ipamorelin and sermorelin, if I'm on a GLP-1, which is the biggest thing I probably will get into here in a bit, is that GLP-1s are great for inflammation and weight loss and metabolic disease. And when you're on a GLP-1, you want weight loss. Sermorelin is very often the thing you want to go to. Sermorelin does a good job at helping improve your muscle mass as you're starting to lose that weight on the GLP-1, which is why we like mix them together. And obviously, testosterone and ipamorelin is great for that. But if I put someone on testosterone and ipamorelin and they're on a GLP-1 and they have water retention, they are going to be very angry. They're not losing the weight or the weight's come back up. They're like, wait a second here. I'm just lost 10 pounds. I'm up eight. And I'm like, I'm so sorry. It's water weight. It'll go away. I promise. But that doesn't work well with most patients. Most people aren't patient in general, especially you spend a lot of money for this stuff. So I am definitely more apt to give a Sermron or even a CJC 1295 ipamorelin to my patients when I have someone on a GLP-1. Because again, they're going to be more hungry, which is typically what happens to testosterone and ipamorelin. People are hungrier because growth hormone goes up. You want to eat more food, which is not bad. Typically, that can be turned into muscle. It all depends what you're eating. But I do tell patients sermorelin is probably a really good option if you want to reduce that, um, uh, water retention and also not
Mhm.
have as much hunger. So I'm a big fan of sermorelin too for
Okay.
those reasons.
I was kind of unclear between the three. I mean, obviously the blend of IPA and TESA and then Semaglutide on its own. Is Semaglutide
Mhm.
just not causing growth hormone to increase in duration or intensity as much as IPA and TESA?
Yeah.
Yeah.
So I made a video on this a while ago. I did on the blackboard because I wanted to show how much comparatively to taking recombinant growth hormone out it was. Sermorelin is about the same as zero point 0.6 to zero point 0.8 um, IUs of growth hormone being given to a patient a day, whereas tesamorelin and ipamorelin is equivalent to 1.4
Mm.
IUs. So it's about 2 over 2x improvement of that recombinant growth hormone given. So you just have a higher output of growth hormone coming out from that. So it's just a significantly stronger option for the body. There's not enough sermorelin I can give you to get that point. Tesamorelin just binds the receptors a lot better. So it's going to have a better output than you would. And then CJC is in the middle. So you can add a sermorelin, ipamorelin. This can be mixed together as well. You could have a sermorelin, ipamorelin mix. You can have a CJC 1295 ipamorelin mix. You can have a tesamorelin, ipamorelin. Ipamorelin is going to be a growth hormone releasing peptide. So what it's going to do is release the brakes on what's called somatostatin, which is basically the brakes on the pituitary. And as you get older, these brakes get pushed down harder, and you want to take it off to release more growth hormone. And then you have sermorelin or CJC 1295 or testosterone. These are all growth hormone releasing hormones. They're going to be just what they sound. They release more growth hormone. So think break for the ipamorelin, and then gas when it comes to the growth hormone releasing hormones. So when you put the gas down with your sermorelin and you don't have the brakes coming off, you can't make as much. So sermorelin ipamorelin mix would be better than just sermorelin by itself, just like testosterone and ipamorelin is be better than just by themselves. We like ipamorelin because there's no raising cortisol, there's no raising prolactin, which is more common with the other growth hormone releasing peptides. Um, there's also the least amount of hunger with it. So it's like the best overall profile. There are stronger growth hormone releasing peptides. GHRP6 is stronger, but it makes you so hungry. Like you will eat everything in sight without thinking. No one wants to be on this. There's also more cortisol. You get more bloated. Like people don't like this one. So ipamorelin is pretty much anyone that compounds. It's like ipamorelin all I'm going to do. If you're going to do one, do ipamorelin. So sermorelin is significantly less strong by itself than adding sermorelin and ipamorelin. Again, the brake coming off and gas going down is going to give you your best push. And you want to pulse it. The other thing that people talk about is growth hormone versus the growth hormone peptides and growth hormone secretagogues. Growth hormone by itself is going to be just a straight flat line of growth hormone. You're not going to have any pulsation, which is what the growth hormone peptides do. We like pulses because we naturally do that. It also releases one single isoform. So when you give growth hormone, it's one isoform of growth hormone. Just so people understand, our bodies make several isoforms of growth hormone. So when you're naturally pushing out your own growth hormone, you make these multiple isoforms, which protects against diabetes, protects against water retention. So you have less of that if you take growth hormone. So that's why we don't mess with growth hormone in practice. I'm not a big fan of it. If patients really ask for growth hormone, like I'm hard pressed to even consider it. The peptides are much safer long term. And again, they're softer on the body, so people can be on them without having like any adverse worries.
Hmm. Yeah, that's fantastic. And I didn't realize you can quantify growth hormone peptides like that. So very
You can,
helpful.
you can.
Yeah, thank you. I wanted to circle back a little bit because you do
Mhm.
work with hormones. You said most of
A
your
lot
friends
of
aren't
them.
on peptides, they're on testosterone. So we
Hmm.
know that research has shown that women who have their estradiol, their progesterone dialed in, perform better on GLP-1s from a weight loss perspective. But I am curious to know about the testosterone component because I haven't read a lot about that compounded with GLP-1s. And I want to know your numbers clinically. What
Yeah,
does a woman function best at for her testosterone numbers in perimenopause? And then what does that look like compounded with a GLP-1 for weight loss?
yeah. Great question. Um, so women need testosterone as much as men. Unfortunately, women are left out of medicine a lot. They are not tested. They are not looked at things. So there's no testosterone on label for women. For men, if you have low testosterone, we will give it to you. Here's the clinical area, and here are the symptoms, and we'll give it. Women, you can have the same symptoms and you could be out of the range, actually be lab low. And your doctor, most of the time, unless you're seeing someone that works with hormones in some way, will say, I'm really sorry, Jennifer, you don't need testosterone, or you just not going to give it to you. Women don't need it. Well, what do you mean? I have every symptom that my husband has, and he's getting testosterone because he's low and I'm lab low and I'm not. What's the problem? We don't have any idea how it works in women. What do you mean? It's a hormone. It's the same hormone that's found in men. I'm confused. So there's just not enough. There is good data on it. There's plenty of human studies in women using it. Unfortunately, the FDA has never said it is on label to treat anything in women. Now, what does testosterone do for women? Does the same thing for men. Libido, fat loss, muscle gain, mood improvement. So anxiety, depression get better, sleep gets better, brain function gets better. Motivation, this is the big deal, miss out. Motivation to want to do things gets better.
Mm-hmm.
And the biggest thing is energy. If you have afternoon energy problems, you find yourself crashing in the afternoons. Like I'm just 3 o'clock, 4 o'clock, five. I'm just like, I could take a nap. I'm just done. Like my energy just crashes. It's most likely testosterone. It's the number one thing. So what I'm looking at is when I look at testosterone, the lab range, we have to remember, is 95% of people. So when you look at labs of anything, it's the population being tested. So each lab has its own lab range because each lab has its own group that it's testing. So the lab range for testosterone ranges anywhere between 2 to 4 nanograms per deciliter for total testosterone, all the way up to either 45 to 65, depending on what lab you're looking at. Now, labs are great. They really do help direct clinical practice. But the question is, how do you feel? So if you come in to see me and your labs and you're in your maybe mid 40s, 45, and you have a testosterone of, let's say it's 38. And I'm like, okay, 38 is not a bad number. It's close to that 45, which might be, well, this lab shows 45 is the top. But if you're coming in saying, I've been tired lately. Gosh, my libido is tanked. My look at my husband. There's no way I ever want to have sex in any way, shape, or form. I'm losing muscle mass. You're naming all the symptoms that I'm wanting to hear to say, well, we could try this. The nice thing about testosterone is giving to women isn't going to stop you from ever making it ever again. We can just do a trial run. Hey, we give it to you for a month. Let's see how do you feel in a month? We start giving testosterone to you and we get you to the goal for me when I put you on testosterone is 80 to 120 nanograms per deciliter after 7 weeks. After 6 weeks of being on it. It takes about 6 weeks to get to the half-life we want where you need you to the right dosing. And at that time, when I have you at that, I want to see again now what negative symptoms do we have? What adverse effects do we have? That's when we start adverse symptoms and we see what the levels are at and what do we have that's cleared out? What symptoms have we gotten over? The reason I push for so hard, because even the lab high is 65, is as we get older, receptors don't work as well. It's part of the aging process. We lose some receptors. So I go a little above and beyond what's physiological. Now, I like to do sub-Q injections for my patients, my women. I think it works so much better. No one wants to do IM needles. They don't like that. I'm not a big fan of creams. When you utilize creams, creams only work on the free fractions of testosterone. So I can't look at total testosterone, have any idea going on. I can't look at your blood work and say, there's no change. I can only clinically ask you how you feel. There's no way I can tell anything with creams. So I'm just not a fan of creams. Oral go through the liver. I'm not a fan of having the liver and being on this. Because again, what happens when you start testosterone, just like a man, you can stop whenever you want, right? There's no requirement to be on testosterone forever. But Jennifer, you come back in 5 weeks and say, this is the best I've felt in 5 years. You're not going to want to stop. You're not going to quit. My women very much understand longevity better than men. Women do a lot of skincare. And you start when you're young and you don't ever stop. When I ask a woman when she's going to stop her skincare routine, she looks at me, I'm crazy, right? I'm not going to stop. There's no reason to. And hormones the same way. They're not coming back. You're not going to get more testosterone when you turn 60 when you were 50. Sorry, it's just going down. So this is how hormones work. We can just replace them. So I'm always telling women, you're on this for as long as you possibly want. These are the levels they want you at. As long as you maintain that, you're not having symptoms, we're good to go. So adverse symptoms of testosterone, increased hair growth. No one wants that. It's about 7%. We have about 3% of women that have passable acne, one pimple extra a month. The hair growth is like, you get one chin hair, you get two. It's not crazy. And typically the third one is 1% of women get some hair thinning. All three of these can be corrected if you're seeing the right person. They're correcting it and they're monitoring you, or they can change your levels. Lots of things we can do to protect against that. I haven't had women stop because of adverse effects. We've just managed them from possibly changing dosing, possibly giving some other things like saw palmetto to help with things like hair growth. There's things we can do to reduce the risk of these things happening. So, saw palmetto for hair thinning. But there are lots of things we can do to prevent this from happening. So on a GLP-1, why do you want testosterone? Number one, muscle loss. When you're on a GLP-1, muscle loss is one thing we worry about all the time. I can correct your diet. I can say, take more protein. Please go lift heavy weights. That's great. But you are going to be losing 1% of your muscle every year and it's starting in your 30s. 30s is 3 to 8% for that whole decade. 40s is about 3 to 8% for the whole decade. And you hit your 50s, and it's 1% after that. So you've already lost between 6% and 16% for 20 years, and now you're losing 1% a year there on after.
Mhm.
Testosterone's going to bring that muscle back. Testosterone is the currency of aging. You start to lose muscle, you're going to age faster. You fall down, you can't get yourself up to the floor, you can't carry groceries home, you can't bend over and pick up a toddler as a grandparent. Like, no one wants these things. You need muscle for these things. Testosterone drives muscle growth. It's very important for that. I don't have women that are coming to see me and getting testosterone, becoming bodybuilders. They're not doing shows. I do have women that want that. Don't get me wrong. We do that. But that is most of my women that come in here. You'd think they look like just anyone else. They're not massively, built and look like a big, muscular woman. They're not looking like the women you see at bodybuilding shows who possibly have used too much testosterone, have some androgen features. We've all seen this women, and all women are like, there's no way I want to look like this ever. That's not what we're creating. We're creating women that just look like you. All we're doing is just building a little extra muscle mass. So when you got on GLP-1, people care more about being in better shape, right? It's better body composition. No one is coming to me and saying, God, I just want to lose like 40 pounds. I don't care how I lose it. I don't care if it's all muscle. I don't care if it's all fat. Because when you get down to that weight, you see your body like, well, I still look fat. I don't understand. I just lost 40 pounds. How do I still have all this flab? I feel like there's nothing left. Well, muscle is what's going to hold that shape to you. So what we really want to do is hold that muscle, because what people really want to really tell me is, I want my body composition to come down. I want, this is why we use an in-body in practice. It tells me how much body fat and how much muscle we have. The ideal is we build muscle while we burn all the fat off. That's what everyone really wants. People want to come see me and have that body when they lose 40 pounds. They would love that 40 pounds came from just fat. Everyone wants that, because then you look more lean and more fit. Your skin still looks good. If you're losing too much, muscle, you just don't look good. So our goal is to give you the ability to keep that muscle mass on, which testosterone really does. I mean, again, and sometimes people get fatigue on semaglutide. Fatigue is the thing people talk about. Well, guess what? We have testosterone that can help improve that fatigue in you and improve how you feel. The other thing semaglutide and GLP-1s do in general is there are some patients that can get depression and a little bit of anxiety from being on them. It is found in the literature.
Mhm.
It's rare, but if we put you on testosterone, it's going to produce that dopamine. So what happens is semaglutide and tirzepatide work on dopamine changes in the brain. And when they bring down this dopamine, this is why we have the craving control happen. You have less dopamine spikes. So I've had patients tell me they stop biting their nails. I had a woman tell me she hates coffee. I had a woman who loved vegetables and doesn't eat vegetables anymore. She's like, I don't like vegetables anymore. I'm like, not a great thing to happen. Like, I mean, this isn't like a positive benefit of being on GLP-1. So I do tell people, like, when that happens and you have patients that have this, well, guess what? I put you on some testosterone, which you need anyways. You get that dopamine put back in the system. That's exactly what testosterone can work on, is that dopamine in the brain. And you start to feel better. This is what the motivation comes from. So I'm a huge believer in utilizing testosterone in both men and women if they're having symptoms and labs, right? It's not just the labs, it's not just the symptoms. They go hand in hand. Because if I look at the lab low, like I said, the bottom 2.5% are out of the range. That means only 2.5% of women really need testosterone, just like men. Only 2.5% are low enough to get testosterone. That's not a great number, because being the bottom 2.5% isn't really where anyone wants to be. No one wants to get the bottom 2.5% or the top. People want to get A's. What's an A? 90% and above. So we want to put you in that A range where I'm like, this is where the optimization is, this is where you want to get you feeling. These numbers only going like this, and they're only going to keep going down. In your 30s, you start to lose 1% of testosterone a year. So it just starts declining. And all we can do is bring it back. So again, this is where testosterone becomes such a huge portion to me. And I am utilizing my perimenopause, in my menopause women. I mean, shoot, if you have a woman with birth control, they're lowering their testosterone, because birth control lowers testosterone. It raises sex hormone binding globulin, which pulls testosterone out of the system. So we are looking at women and saying, what are your symptoms? Where are your levels? Okay, well, we can try this and see if it helps improve all these things. And most women come back and say, this is the best I felt. So I'll tell you, most of my practice is going to be GLP-1s and a little bit of hormones. Those are the things that make people feel the most. And don't get me wrong, I use peptides all day, every day. I think there's so many amazing ones. But for most patients who just want a little wellness, they don't have to do a lot. Like, this is the thing everyone gets worried. I have to do all these things to say, well, you don't have to do a lot. You just do a few simple things, because the realistic thing is, as you and I both know, if you put someone on a plan or someone does something, if I give them a very detailed plan with a million things they're going to do for the rest of their life for wellness, they're not going to follow through with it. No one will. Like, I know myself, I treat myself all the time. If it's too much to do, I'm not going to do it. I get taking supplements. So I take my supplements, the least amount of supplements possible. Like, I don't want to give you something I wouldn't want to do. There's always more we can add, but less is more in my practice. If I give you less, you're more likely to hold on to the things I'm giving you. If I give you too much, you're going to burn out real quick and say, I can't do this. Like I'm doing 4 injections a day, every day. When does it stop? Well, a lot of things I'm using in practice aren't meant to stop. So when you've added something in, unless I'm treating a specific thing, for example, an injury and using like a BPC 157, well, that's probably not going to stop. If you're using BPC 157 for repair recovery, well, it's not like that's going to fix you in a month and you're going to repair and recover
Yeah.
permanently. That's something you have to take long term. So it's what can we get patients to do long term? And that's when testosterone is easy for me. Simple, single sub-Q injection a week. People are on GLP-1s. It's another simple single injection once a week. I can't make it easier for patients to kind of lose weight, get the body they want, and then they can maintain with the
Mhm.
testosterone. They can just stay on that and keep going and going and going on this for, I mean, we've had patients on testosterone for 7 years, 8 years in my practice. So they just continue being on this protocol.
I'm all for being 80 years old and still being on testosterone. I
You
love it.
should be.
Just be
Yeah.
switching over from my cream now back to an injection. Thank you very much, Jason. I
Hmm.
did want to ask you, you said, we want to keep it simple. And obviously, the more
Hmm.
you stack into a protocol, the less you're going to be aware of whether or not something's
Hmm.
working, right? So I like
100%.
this idea. Okay, optimize hormones, get on a GLP-1. You said that you were using liraglutide in your practice 6 years ago.
Hmm.
That's an everyday injection where your patient's injecting
Yeah.
every single day.
They hated me. I
Yeah.
took it. I didn't like it either. That's why I quit. I mean, I fell off. And so I tell people like even I'm gonna fall. Like if I know I can't do it, there's no expectation for a patient to do it. So I try every peptide I've talked about. I think we have two cancer peptides that I haven't tried.
Hmm.
Other than that, I've tried everything else in practice. I'm very adamant that if it's gonna be in my practice, I'm trying it. So all the injection therapies, all the peptides, stem cells, exosomes, IVs, if you name it, other than estrogen and progesterone. Like actually, I've tried progesterone. Progesterone is great for men for sleeping. So men out there that want to sleep better, I use progesterone heavily in them. It works well. It also creates more testosterone in men, so it's not a bad thing. But I use low dose because progesterone for sleep is like one of the best things you can do. So only thing I haven't taken is estrogen. It's the only thing I haven't taken in practice when it comes to hormones. And I'm on thyroid meds because my thyroid's really
Yeah.
optimized already. But I've tried everything else. And I tell people all the time, I'll try all the things I use in practice. If it's in practice and I've got it here, I'm going to use it. So I know what to expect and also not experiment with anyone else first. And I will say that the GLP-1s were like probably the biggest thing that came to practice. And I hated doing injections every day. So I dropped it. I was like, it's not really worth it. And this was when liraglutide came out, I was still overweight. Like there's probably, I think it's like, I want to say there's up to like an 8 kilogram weight loss, like 16 pounds is like kind of the max weight loss. So it's not like the 15% of sema or about almost 20% of tirzepatide. There was like 7%. And I could have used it back then. I just did not like taking it every day. It was very expensive comparatively. So I stopped using it. And again, it's whatever can make it easier for patients. If I'm not willing to do it, I'm not expecting you to do it. And that's kind of been my philosophy this whole time. And again, I'll be like, if you're willing to do it, I'll give you this. Like I'm willing to give whatever protocol, make it as deep and detailed as patients want to do. I've just seen so many people fall off. I had patients who want to do everything at once. They're like, oh no, don't make me start this and then add things slowly. I always want to start things slowly, just like you said. Like we want to see what's working, what's not working, what's causing a reaction. If I do all this at once, we have no idea what's working and what's not working. So most of the time, I'm like, here, we're doing this first. Usually it's hormones first. I will sometimes start GLP-1s and hormones at the same time because they work on totally different areas. So I'm less concerned. But I definitely don't start hormones and like a growth hormone peptide at the same time because they cross over. And how do I know which one's working? We want to find the things that work and keep on those. And the things that don't work, we just toss out. So all my protocols are, I guess, are all per patient. Everything's built out to the person that I'm seeing. A lot of clinics I know which like here's the protocol. You want weight loss. These are the 7 things we do, and everyone's doing this exact same thing, and just that's it. This protocol works for everyone. Well, we're all individuals. So maybe this doesn't work for everyone. Maybe you're paying extra for something that's not doing anything to you, or maybe it's actually hurting you and your weight loss goals. So we take it out of there. And you won't know we start everything once. And the patients that have started everything have been adamant. I want all this at once, which I'll do. I would tell you 6 months to 9 months later, they'll drop, they'll quit. They'll be like, I felt great and I quit because I felt great. Okay, well, what happened? Well, I felt really good, and I thought that was it. I thought that was I'm good now. I'm like, no, this is why we do all this stuff long term. Like, you need it. So they didn't understand the value of what they were doing because they didn't add things in one at a time. So you start with one. Then you add the next, and you add the next. This is the hare and the turtle, right? We have the turtles like nice and slow and going along. We're just slowly getting there. We have a long race. We have a long life to live. And if you're not doing things slowly, you're not going to know what works. My mom is turning 80 this year. She's been on peptides now for 7 years since I started this. She started with hormones first. And after her hormones, she's like, oh my God, I didn't realize I could feel this much better. She, just was told like every woman in her 70s, I'm sorry, but just get used to feeling bad. This is part of life. You're aged, you're older. Right? How many women get this told to them?
Yeah.
Well, I'm sorry. Good
Yeah.
luck. Suck it up.
Hmm.
You're in perimenopause, you're menopause. This is just how you feel. You're tired, you're fatigued, you don't feel good. You're on depression. We'll give you an antidepressant. You got some anxiety. Here's, some sertraline, some Zoloft, or some Xanax. Like you're good. You can't sleep at night. Take some Ambien. You're good, girl. Like women are so often gaslit in the medical community and just told it's part of aging. I mean, men are too. We're told the same thing. Men just don't ask questions. Men just like accept them, like, well, whatever, who cares? Like, you're right, I feel bad. My doctor said I feel bad. I'm not going to go to my doctor. Well, they can tell me I can do anything. Dude, you went to the doctor and you said they didn't do anything for you. Why am I going to go? So I get men don't want to go because no one's going to help them. Women don't want to go. Women get frustrated because they go to the doctor and ask for help and they're not getting help. And it's not the appropriate help. So I understand the frustration, but I'm very adamant to tell women like there is things you can do out there for this stuff. So I start them low and slow. We do one thing, then we add another. My mom started on hormones. She's like, this is the best I felt. I didn't know I could feel good. And then I think the second thing we started on was growth hormone peptides. Yeah, we did CJC 1295 ipamorelin. She was on it for probably 9 months of hormones. Then we added CJC and ipamorelin in. And I remember her coming back and she's like, I've moved up 5 pounds in my weightlifting. And I was like, 5 pounds is not a impressive number, mom. Like, I mean, just letting you know. And she's like, no, I'm like in a Zumba class. She's, 73 doing Zumba. So she's in the class and they'll step up the little Jane Fonda workouts. And she's like, no, but like I'm doing like curls. And like 5 pounds of like 50 curls is a lot of extra weight. I'm like, oh, there. That's very fair. And I had pictures of her, which I should post at some point. Her before and after her 65 to 75 was this amazing transformation. People are like, oh my God, she's aged significantly backwards. And she's the last picture I have, I have in my wedding a few months ago, but at 78, she has a photo next to me. I'm standing there and she's just jacked. I mean, she's 78, she's doing a Zumba class and she's doing, like pickleball and golfing. Like she's not weightlifting. And you look at her and like, how is she so muscular? Because she's on things to hold muscle mass. It makes it easier for you to gain muscle mass. So we added things. Each time I add things, and I added BP 757, and she's like, all my aches and pains are gone. I'm like, what aches and pains? She goes, you don't understand. When you get to your 70s, everything just kind of hurts a little bit. Everything just doesn't feel as good. And I'm like, well, why didn't you tell me? She goes, well, I didn't know there was a treatment for this. I just assumed because of what I've been told, this is part of aging. I just want to tell women, like, it doesn't have to be that bad. There are things that can be added in. And so she's on NAD, she's on BP
Hmm.
757. I have her on CJC 1295 ipamorelin. I have her on a little bit of GLP-1 just for metabolic disease in general and hormones. And she's like, this is the best she felt. Her joke right now is, my life insurance policy ends at 101. Should I cancel it? I'm like, I love you to death, but we're gonna keep that, okay? Like, we'll see. You're at 80. We got 21 more years. We'll talk then. Um, so yeah, so I've been using this stuff for very long. It was a slow for her. She was the slowest patient because I had time. Again, it's been years. And here at 80, she's like, she doesn't look at all her age. Everyone that sees her is like, I think you're in your 50s. The biggest complaint she has right now is actually her fatigue and her testosterone, or not testosterone, her thyroid is low. So this is a big thing checking women as well as thyroid. I put her on thyroid and her doctor was like arguing with her, saying that her thyroid numbers are too high. She shouldn't be on it. And I love them to death, but she listens to her doctor, even though I'm the one treating her. So she got off. And she's like, I was feeling great. I'm so tired again. I'm like, you quit the thyroid, mom. Like, what do you want me to tell you? Well, he told me that my thyroid was too high. I go, I love you, mom, but who's treating you? Like, who do we go to talk about this stuff? So I love her to death, but her biggest complaint was fatigue in the afternoon. She's like, I get up at 6 in the morning to go work out. I'm tired by 9. I'm like, that's pretty normal to me. I get up early, and by 9 o'clock, 10 o'clock, I'm ready to go to bed. So the thyroid actually was a huge help. She felt really good on her thyroid meds. She was doing so well. But that was the only thing she complains about. So I always try to tell people we have years. I have had 8 years, and I've reversed like the way she looks, the way she feels. It's all been put backwards, and it's been a slow process. It didn't have to happen overnight. I know that everyone wants things to happen at once, but if we do it all at once, people get burnt out and are like, I don't want to do this. Like what? And then people always then budget. Like, obviously, the other thing comes in is budget. This stuff's expensive. I'm not saying, this is not covered by insurance. So it's like, well, what's the least amount we can do to get the biggest bang for my buck? And for me, it's always going to be hormones and potentially GLP-1 if you're overweight, or if you don't want a GLP-1 because your weight's where it's at, then a growth hormone. So if I can get patients on growth hormone peptides and get them on some kind of hormone replacement therapy, and that's all they do with me, I have patients come back year after year and be like, I still feel great. Anything else I'm changing? No, unless you want to add more, we can always add more. The well is deep. I have more to add. But especially when it comes to, how long I can be on it for, less is more. And then also budget. What am I willing to spend on my own health as I get older? And that budget changes as we age. So
Yeah. Great example there of Mama Pencek. I need to see a
yeah,
picture of that because I mean a
she looks great.
10-year reversing
Oh,
of
she looks
age
great.
I think is fantastic. And it also begs another question that I get often, you probably get often. It really is a beginner question, but we get it all the time. Are these safe? How long can I stay on them? So you're telling me your
Oh,
mom's been on some of these therapies for six,
8 years.
8 years. You've been using them
Hmm.
clinically for 6 years. You're using them in yourself. My
Hmm.
own personal opinion is I'm, Lord willing, never going off peptides. Like I love my
Yeah, for
peptides
sure.
diet, right? But other people are a little bit worried, yes, with the expense and are they safe? And then what
Yeah,
does that look like long term? So can you speak to that a little bit just for the
of
general
course.
population?
Yeah, so I mean, hormones, for example, for sure safe. The FDA just removed the warning labels for women on estrogen and
Estrogen.
progesterone. Yep. So we now are saying, okay, well, we don't think they're as dangerous as they were for an entire generation of women. They missed out on hormone replacement therapy because the WHI study basically said estrogen causes cancer. They were very wrong about that, unfortunately. And because of that, everyone stopped prescribing. Actually, it's not the estrogen that causes cancer. It was actually the progesterone in the study, but everyone said estrogen, which is even more horrific. And it was actually horse urine is what it really was. It was a synthetic urine. So bioidentical hormone replacement therapy is one of the safest things you can do. It will reduce your risk of heart disease. It'll reduce the risk of colorectal cancer, reduce the risk of osteoporosis. It brings inflammation down. So a lot of women have inflammation. Your estrogen blankets your whole immune system and keeps it just calm. When you take estrogen away, you have inflammatory cytokines like TNF alpha, interleukin 6, interleukin 1 beta. These are just letters and words to most people, but these are inflammatory cytokines in the body that raise inflammation. This is where the pain comes from. Your just joints don't feel as good. Estrogen given back to women will bring those down. So the amount of estrogen given to women is still lower. My goal is 60 to 100 nanograms per deciliter of estrogen. Most women get to 300 plus when
Hmm.
they're still cycling. So it's still lower than giving women than they are cycling, which still means some of this inflammation is still there. Again, this is where GLP-1s come in. And I'm on GLP-1s long term because GLP-1s lower these same inflammatory markers. So now pain and inflammation all come down. So my perimenopausal women and my menopausal women are the ones who want to stay on these GLP-1s for the life because they're like, my inflammation's down, my pain level's down, I feel better. How long we run that for? As long as we want. The GLP-1s have been out since 2007. Exenatide came out. People have been taking it, still on the market. People probably switched at this point to being on stronger ones because Exenatide does not work as well as everything else. But people have been on these things for, 10, 15 years. So we have clinical data showing these things can be out there. Hormones, people stay on, their whole life. There was some research showing that past 60, women would stop, and then they just took that information away and said, nope, we're not really worried about this now. So when I start someone on hormones, the data has shown long term, there is no adverse long term risk that I worry about. Now, the caveat to all this is you get breast cancer and you're on, for example, HRT with estrogen and progesterone or testosterone. It can be single, double, or triple positive, which means you can have any of these three hormones. So if you're single positive, it's typically estrogen. If you have estrogen and you have estrogen cancer, related breast cancer, of course it's going to grow. Like that's it. So it's not like it's going to cause the cancer, but it could make it grow. Same with growth hormone peptides. I tell people the same thing. Growth hormone is not going to increase your risk of cancer. In fact, being on the growth hormone peptides will increase something called immune surveillance. So immune system can find something growing and clear it out better than if you were not on it. The caveat is if it does get past the immune system and somehow bypasses that and starts to grow, it's going to grow faster in growth hormone peptides. So because again, it's growth. So I'm not saying no, you can't be on this long term, right? What I'm telling you is work with someone that knows what they're doing. Talk to someone that knows what they're doing. Don't just DIY it. You don't do it yourself. Have someone else that can monitor some stuff, or at least tell your practitioner you're doing this stuff so they can monitor and look at some of these markers. There is no good cancer test that exists right now. There's a couple that exist. You can go to Pronovo and get a full body scan, see if you have cancer. You can do what's called the Grail test. Grail does blood testing. But if you're negative, 40% of the time, it's either 40 or 60% of the time, you have a negative, you still could have cancer. So it's not a 100% guarantee. So I don't tell people to go do this. It's not, it could give you false sense of security. So I'm not big on like the cancer testing that exists right now. It's an option. People are really worried. I have people ask me, should I start doing a cancer test before this? No. I mean, even NAD could grow cancer. So there's so many things that can cause cancer to grow. I mean, eating, again, I know this is a bit different, but eating too much sugar will have your cancer grow. And again, I know it's not as strong as giving growth hormone, but it's still going to grow your cancer. So I'm telling people there's lots of things you're doing now that might grow your cancer. So do you want to live your life in a bubble? No. Like do these things. If they work on you, awesome. I'm not saying these cause cancer is the big thing. So I'm on these things as long as I possibly can be. I will be taking a GLP-1 for as long as I can. I will be taking growth hormone peptides as long as I can. I will be on hormone replacement therapy as long as I can. These things are meant to be long term. There's a lot of things I do long term patients. It's sometimes I cycle them. For example, I might switch between CJC12 and I5 ipamorelin and tesamorelin ipamorelin. Tesamorelin has one study with 26 months of data on patients. They did 26 months of tesamorelin and they were just fine. 26 months. And again, I understand that's just 2 years, but they showed up for 2 years. People were on it nonstop and had no issues. So theoretically, we believe that changing growth hormone releasing hormones, growth hormone releasing peptides is probably a good thing because it lets the receptors get a break because slightly different receptors are hit when you use one versus another. But that's just a theory. We have no proof that this is actually a problem, that they might get burnt out by having this or involuted go inside the cell. So I will keep patients on these things. I have had patients on growth hormone releasing peptides, growth hormone releasing hormone, the same ones for 5 years, a couple of my
Hmm.
patients, and it still works. They still feel great. They stop because they run out and they get it back on again. I always tell people, people self cycle pretty frequently. Like you ran out, you forgot to get more, or you just didn't have access to it for a week or two, and you just kind of that's your own little break. There are very few people I know that are like continuous nonstop. I'm going to do this no matter what. People do breaks on their own. It's just naturally how we do stuff. I take breaks on my own. So if you are someone that's like so regimented, I do this forever, I would say maybe taking a break from a growth hormone peptide for, I don't know, 2 weeks to 4 weeks every few months is not a bad move. If my patients are that regimented and they tell me this, I will have them take a break for 2 to 4 months. If they're like, I'm on it nonstop, I've never come off. Okay, well, just take 2 weeks off, 4 weeks, let yourself have a break, and then go back on it. It's not the end of the world. GLP-1s are ones that I don't typically people come off ever. And I will say that that's for low dose, and I'm using low dose of it. So this is, not weight loss dosing. This is like longevity dosing. I'm using for cardiovascular disease and heart disease risk reduction and Alzheimer's risk reduction, Parkinson's risk reduction, um, inflammation reduction, cancer reduction. The new study just came out showing that there is a decrease in heart disease in people
Hmm.
without having any change in obesity. So originally this was thought GLP-1s reduce heart disease because people lose weight. And this study just came out and said, absolutely not. GLP-1s don't just do that. In regardless of losing weight, you still have a lower risk of heart disease. So it's like the number one killer in the United States is going to be heart disease. Why do not put you on something that's going to keep you from having this happen for as long as humanly possible? It makes no sense to me. Like, please take this to reduce your risk of heart disease. Why would you not do that? So long term, yes, you can do a lot of stuff long term. I'm not worried about most of these things. And it depends on the peptide. Like dimethyl beta 4, for example, that's a peptide that causes some angiogenesis. Potentially, we see it go up, and we do see it go up in cancer. It is a peptide we make naturally. That one I cycle. So some of these I will cycle, but it really depends. The top ones I do, hormones, I don't cycle. I don't cycle my GLP-1s, and sometimes I'll cycle my growth hormone peptides. So
All right. Cool. Do you happen to remember off the top of your head what the dose was for that study? Was it semaglutide or tirzepatide with the cardiovascular event?
semaglutide.
Okay. What was the dose? Do
Yeah.
you remember?
I just saw it yesterday. I didn't get to read the whole
So
article, but I was
interesting.
just at a Peter Attia just posted it. So if you look at Peter
Hmm.
Attia's account, he has the information, he has a carousel on it. And I was in a seminar this weekend on endocrinology, and we talked about GLP-1s. And I basically wrote the whole pathway out. This is the reason why it works, because it goes through the beta cells of the pancreas and raises insulin, and insulin goes to the cell, and when it goes into the cell, it works on IRS1, which goes to PI3K, which is going to work on basically GLUT4 receptors. The whole point of this whole system is to get GLUT4, which is going to be on the cells and pull in more sugar. When we can reduce the blood sugar in the body, we reduce what's called advanced glycation end products,
Mhm.
AGEs. When you reduce this, you reduce the oxidation that's going to happen at the blood vessel level that's going to cause more plaquing, more inflammation. So lowering blood sugar alone is going to reduce the risk of cardiovascular disease. And guess what? GLP-1s do this incredibly well. GLP-1s will they're called incretins. They're going to put out more insulin, which is really actually not a bad thing. And, when you look at the data, like if I lower your blood sugar, I can lower the risk of heart disease. That is like automatic to me. And that's what the number one thing I think is doing it.
That is so fascinating though. I mean, you don't have to lose weight on a
No,
GLP-1 to have the cardiovascular
no,
benefits. That is
100%.
really, I'm definitely gonna look into that as soon as we hang
It's a
up.
big one. It's a big one. I think
Yeah.
everyone should talk
Yeah.
about this. This has just came out, and if you are on a GLP-1, you have a lower risk. And everyone's always said it's the heart. It's because you lost weight. It's not. It is
Uh-huh.
not related to the heart, the weight loss. It is related to just what GLP-1s do. And it's like they, Peter Tejas makes saying we don't really know why. I'm like, well, I'm
Yeah.
pretty sure this is the pathway that's doing it. And Peter's very smart. He knows the pathway, so I'm sure that he's maybe ruled this out. I don't know, but I'm like, this makes sense to me logically. I just did a whole pathway this weekend of it, but maybe there's something else it's working on. We don't know, but we do know that it does reduce the risk of heart disease. Number one killer is heart disease. So anyone wants to argue with me left and right about GLP-1s, I want to say, look,
Yeah.
you're reducing the risk of heart disease. You want to come out with me about cardiovascular, about thyroid cancer or pancreatitis and all this other BS that people say on the stuff, my vision, there's all these things that people say. And I'm like, the risks of those are 0.1% or less for any of these things to happen. But your risk of cardiovascular disease being lowered by 20%, how is that not being the number one thing we focus on? Like, you're not going to die from any of the other things, are very likely. So low. But if I can reduce your risk of heart disease by 10%, that automatically saves more
Yeah.
lives than being on anything else. So it's like a no-brainer to me for patients on these. I'm like, I can get you to live longer. I don't know what else to say. And people get so up in arms. GLP-1's a bad. God, I can't remember who the doctor is that talks about this. Talks about it being lizard venom. It's in the venom of the Gilead monster. That's where
Yeah.
we found GLP-1s. There's some guy who talks about this. I've seen plenty of his videos discussing this. There's more than him, just him. There's plenty of people online talk about this stuff. It was found in the venom of the Gilead monster, of
Yeah.
course, but it wasn't used to actually harm the animal or do damage. Gilead monsters live in the desert. They must take, they must have their food digest slowly because they're only having one meal a month. So what they did is increase their GLP-1 production to slow the digestion down so they can slowly digest whatever food they're bringing in, this whatever animal they're eating, because they need to slow it down so they can get this one meal a month and survive on one meal a month. It was designed to help them control their blood sugar, which is what we use it for, and slow down the digestion, which is what we're using it for. So it's like the people that say it's the venom. Sure, sure, great, it's in the venom, but it's not used to be poisoned. It's used for the animal to help it live its life and actually have one meal a month consume it. Like, I get so angry when you hear this. I'm like, you don't understand the mechanism of action. Like, just get so angry because it's not how it's being used. And we know how GLP-1s work. We have data for years about how it
Yeah.
worked in humans. And
Yeah.
we found out this animal eats one meal a month. And we're like, oh, how do we get people to eat less than once a day? Like,
Mm.
how do we do that? Oh, GLP-1s can help. Done. I would tell you the number one
Ta-da.
thing, people that have issues with blood sugar, insulin sensitivity, if you can get someone to fast, you can change the blood sugar, you can change insulin sensitivity. But getting someone to not eat for 5, 10 days into a water fast is near impossible. It is so hard for us not to eat. Well, guess what? Now we have an option to reduce, basically, it's causing fasting. We're causing fasting
Mhm.
with
Mhm.
people, which then changes blood sugar and insulin sensitivity because they're eating less. They're less calories come in and they're basically forcing a fast. I'm like, this is the whole point, and this is why we're fixing metabolic disease. We found something saying, hey, people, eat less. Like, that's a lot of it. You're eating less, and this change is part of the reason we're seeing these metabolic changes. We see cholesterol change, we see LDL change, triglycerides change, we see insulin. There's just so many things this works on. Anyway, yeah, it's my high horse.
You're
I'm
fired
sorry.
up
I
about it,
love
and I
it.
love it.
I
I,
get
I
I
mean,
get
I
super
will.
excited.
You can tell it's great, but I'll ask my clients if you ask any 4-year-old around you, how do you lose
Mhm.
weight? What's that kid gonna say?
Don't eat with food. Stop
Simple.
eating.
Eat less. Like eat less
Yeah.
food. That's how you lose
Yeah.
weight. And you're right. Like now we have a tool that makes it easier to do what biologically has to happen in order for us to lose mass, really fat
Yeah.
mass. So yeah, that's a great reminder.
And let's also be fair, because there are obvious women out there that you work with, that I work with, that I've tried this. I can't lose weight, not even
Sure.
GLP-1s.
Sure.
I tried eating less. Well, not everyone's problem is not eating less, right? That's not everyone's problem. Could be you have huge toxic load. Could be your thyroid doesn't work. You have absolutely no thyroid and you have no metabolism function, right? There is calories in, calories out. When you have a high toxic load, there's no calories going out. We can measure calories going in, but we don't know the output very well. So I always want to caution people, it is a simple equation, calories in, calories out. We know this, right? Ultimately, this is what it is. But if you don't know the calories going out, okay, because you have some kind of toxic load, you have your hormones aren't balanced, then you don't know, it's hard to get, I get patients to like, they get so frustrated, but it's not just calories. And I've done that before. I'm like, I get it. But do you have a toxic burden? Do you have pesticide, herbicides,
Mhm.
Lyme disease, mold, heavy metals blocking this? Do you have endocrine disruptors that you've been exposed to? Like, where is the problem that's caused this? I have a patient right now who's you did a total toxin burden test, and you can every toxin I can imagine. I've never seen more red in my whole life. And she's
Hmm.
like, I can't lose weight. She's young, in her 20s, and she did a GLP-1. She lost the weight, went all right back. Why? Because she has this huge toxic load that's changing her calories out, even though she's eating super clean. She's doing everything right, exercising correctly, but she just cannot keep her calories out high. So I'm gonna work on this. So again, GLP-1s 100% are gonna help that. And for most people, that is the issue. Most people, the issue is stop eating so much food. That is a lot of people's issues, not everyone's. But there are other things that play into it. But this is why we see this weight loss in people, because
Mhm.
most people, this is the issue. Just
Mhm.
have to eat a little less. And GLP-1s make it so easy. It's the training wheels to put in place to say, this isn't the fix. It's, hey, do this. And while you're doing that, eat more protein.
Mhm.
Change your lifestyle because you're going to come off this stuff, take your training wheels off, and all of a sudden you're going to be hungry again. And you're going back to eating all you did. If you don't, that's the biggest thing about GLP-1s that just I think we both, everyone agrees on is if you don't have something in place to keep that weight down, you're screwed, right? You're going to go
Yeah.
back to eating the same thing you did before. And if someone's not working with someone like you or, talking to a nutrition or a health coach, they're going to eat that food back and say, well, what the heck? I gained the weight back. Well, but did you change your diet at all? Well, no, I just went back to eating what I did. Well, what did you think was going to happen when you ate the same thing you ate before? Like that's kind of what I expect, right? That you did what did Einstein say, like the definition of insanity is doing the same thing again and again, expecting a different result. Like, how do you expect anything to change if you're going back to exactly where you were? So you need nutrition to change, you need exercise to change. Like if you don't do hormones, right, you at the very least have to change nutrition and exercise to maintain this when you come off, or to even help yourself get there faster. So
100%. Now, I know you got to get back to the clinic. Thank you so
yeah,
much for giving us an hour. I do want to
of
ask, where
course.
can people find out more about you and your clinic?
Oh yeah. Uh, if you go to Dr. period Jason Pencek, Pencek, I'm on Instagram. I am technically on TikTok as Dr. Thirst Trap. It was an old name. I don't post anything on that really. I think I'm going to start getting a team to start posting on that sometime in the near future in 2026. I'll be starting a podcast here soon, starting in 2026 as well. And then I have a clinic, Thought Wellness. It's on my Instagram page. You can go there and check it out and just look my clinic on there and click it and come check me out. So
Excellent. And yep, you are a fantastic educator. So, I mean, looking up videos on how you're using GLP-1s in your practice has been really helpful. I've seen them on YouTube. I love the stuff you do. Is it ISSA?
it's got ISSC. Yeah, I also train on
Yeah.
peptides. So I teach across
Mhm.
the world in peptides. I have speaking engagements all over. I'm supposed to go to Jordan, I think. They just email me the next month or the month after. I'm supposed to go to Jordan and go teach on this stuff. So yeah, I teach worldwide on peptides and on GLP-1s and stuff. So
Very cool. Bon voyage. Have a great trip. And thank you again for giving us your time today. Really appreciate it,
thanks,
Jason.
Jennifer.